working in progress.
Good morning, everyone. I am Dr. Luzsil Catedral. I am an ENT hand and neck specialist. So today I'll be talking about the diseases of the external ear. So the objectives of this lecture is to discuss the basic external ear anatomy, discuss the common diseases of the external ear, familiarize the basic and first-line treatment for the diseases. So for the disclaimer, some photos are from the actual patients in my clinic and the others I grabbed from the internet. So this is the anatomy of the ear. So the external ear starts from the pinna and ends at the interior border of your tympanic membrane. The external auditory canal is approximately 1 inch long or 2.5 centimeters. It is S-shaped with some hair. The outer 1/3 is surrounded by cartilage, while the inner 2/3 is bony. This allows air to warm before reaching the tympanic membrane, and it also isolates the TM from physical damage. So the cerumen, the function of it is to moisten and soften the skin, and the presence of cerumen is normal. The curvature of the canal provides initial defense mechanism, and it also serves as protection. So the drumhead and ossicles provide an important role in the initial pathway of hearing. So this is a picture of a normal tympanic membrane. As you can see from the arrows, here is the malleus, the handle, the cone of light, and the pars tensa. Let me present to you the cases I have seen in my clinics. So the first case is a 7-year-old female, 32 kilograms, with a temperature of 37.9 degrees Celsius. The patient was brought in the clinic due to right ear pain associated with decreased hearing for 3 days. Pain was associated with unconsolable crying last night, which was partially relieved by giving paracetamol, 250 milligrams, 10 ml. The mother also noted a whitish discharge coming from the outer right ear. Cleaning was done, but it was noted that the Q-tip can no longer fit the ear canal. So upon interview, she had a swimming history 5 days prior to consult in one of the popular water parks in the city. Upon physical examination, she presented with positive tracheosign, narrowing and erythema of the external auditory canal. There was also a note of a curd-like whitish discharge, which was cleaned by suctioning at the clinic. Tympanic membrane was non-erythematous and intact. The diagnosis was otitis externa, or your swimmer's ear. The main treatment for this disease is debridement, followed by giving oral antibiotics, your penicillins. Antipyretic and analgesics should be given during pain and fever. Your corticosteroids will also be given for the inflammation. You can give it either oral or topical. For your orals, you can give prednisone or methylprednisolone. Your topicals are in the form of fluocinolone and dexamethasone. So the most common etiologic agents for this are Pseudomonas and Staph aureus. For case number 2, I saw a 41-year-old male, non-diabetic, febrile, who came in the clinic due to ear fullness. It was 10 days prior to consult when he started to clean his ears daily. He had this feeling to clean it every day because it was so itchy. He applied alcohol in his Q-tips and used this to clean his ear. It was the morning prior to his consult when he noted that something was blocking his ear after cleaning. So upon PE, there was no trago sign, but the ear canal was erythematous. Lo and behold, we saw a black cotton-like structure inside with whitish discharge completely obstructing the canal. So the diagnosis is otomycosis. The main management for this is debridement or cleaning. You have to start your topical antifungals in the form of clotrimazole, fluconazole, or miconazole. You can add analgesics for pain. What are the different kinds of otomycosis? You can find Candida albicans. They would usually appear like cotton-like or white in appearance. Your Aspergillus fumigatus, they appear having a greenish hue. And your Aspergillus niger, from the name itself, it's black in appearance. In general, otitis externa is an inflammation of the external ear. So it is associated with water exposure. That's why it's called swimmer's ear. from trauma, foreign bodies, and from otitis media also. The most common etiologic agents we have here or species are the Staphylococcus, Pseudomonas, and fungi. Pain is present, followed by ear fullness, itching, hearing loss, and referred pain at sometimes located behind the ear or on the infraauricular area. If you will do your physical examination, you will find that the ear canal is edematous. You can have the tragus sign by pressing the tragus, wherein you will elicit a pain. There's otorrhea and lymphadenopathies. Otomycosis would usually appear or have a curd-like yellow and gray to blackish debris, which is caused by Aspergillus and Candida. The treatment for otitis externa, in summary, is frequent and thorough cleaning by a specialist, wherein your otomycosis would require meticulous cleaning and acidification of the ear canal to inhibit fungal growth. Ototopical agents are important, so you can have it. The popular brands are your Sinalar, your PNDs. Okay, oral antibiotics may be given in cases of cellulitis and lymphadenopathies. Analgesics, such as your NSAID, should be given for pain management. The most important with this is patient education and water precaution, together with proper ear instructions. For our case number 3, this is a 33-year-old female who is a febrile also, who came in the clinic due to right ear pain. She complains of ear pain for 2 days with a VAS score of 6 to 7 out of 10, associated with on and off ringing of the ear. She noted the pain while receiving calls at work and attributed it to prolonged use of a headset. She felt feverish with nasal catarrh on day 1 and relieved by Decolgen. On day 2, the pain starts to radiate to her right maxillary teeth, which was approximately 3 out of 10 by visual analog scoring. She took mefenamic 500 milligrams tablet with temporary relief. Upon examination, neurootologic exams were normal. However, on otoscopy, the eardrum is intact with note of shortened. So, upon otoscopy, the eardrum is intact with note of shortened light reflection. The canal was clean, non-erythematous. There were no masses, blisters, or lesions noted. However, the patient had a positive tragus sign and a very minimal erythema, which was noted on the conchal base. My initial diagnosis at the time was eustachian tube dysfunction, trigeminal neuralgia with systemic viral infection. She was given with combined corticosteroids with antihistamine, high-dose vitamin B complex, and etoricoxib 120 milligrams for pain, and then was advised to follow up after 3 days. So on follow-up, the patient complained of worsening of pain. It was also noted that the erythema on the concha was more pronounced and started to spread up to the antitragus area. There was also a note of single blister at the entrance of the ear canal, approximately 0.5 millimeters. On close examination, there was a note of facial palsy, House-Brackman 2 to 3. The diagnosis now is herpes zoster oticus, or your Ramsay-Hunt syndrome. What is a Ramsay-Hunt syndrome? It is caused by varicella zoster virus, which causes our chickenpox. So there are 2 main signs. One is a painful reddish rash with fluid-filled blisters on, in, and around the ear, or presence of facial weakness or paralysis, ipsilateral to the lesion. Usually, the rash and the facial paralysis occur at the same time. Sometimes one can happen before the other. The other times, the rash never occurs. The signs and symptoms commonly present with ear pain initially, followed by hearing loss, tinnitus or ringing of the ear, facial asymmetry, vertigo or a sensation of spinning or moving, dysgeusia or a change in taste perception, dry mouth, and dry eyes. We manage herpes zoster with antivirals. The most common used in the market is acyclovir. Analgesics are given for the pain, and steroids are given for the swelling, especially for the facial nerve. Prednisone and methylprednisolone are the most common given by doctors. You can give oral antibiotics or topical antibiotics if needed. Still, it is very controversial if with the use of vitamin B complex and vitamin C can help improve symptoms. For the 4th case, A 62-year-old female came in the clinic due to swelling of her left ear. So history revealed that 2 weeks prior to consult, she experienced pain on her left ear radiating to the infraauricular area. She took mefenamic 500 milligrams every 6 hours with temporary relief. So 10 days prior to consult, she went to a local health center and she was given with co-amoxiclav 625 milligrams 3 times a day, wherein she completed this for 7 days with no relief. This prompted her to seek another medical treatment. Upon physical examination, her temperature was 37.4. However, the swelling was so severe on the left external ear extending to the auricle. There was also a note of 2.2 centimeter lymphadenopathy at the left infraauricular area. It was tender. Tympanic membrane right now was not visualized. The discharge draining from the ear was watery and clear. She also presented with facial paresis, Hausbachmann 3 on the left or ipsilateral to the lesion. Other neurootologic exams were unremarkable. A random blood sugar was requested in the clinic, or it was performed in the clinic, and it revealed an elevated result at 400 milligrams per deciliter. Thus, the patient was advised for admission. She was diagnosed with necrotizing otitis externa, or your malignant otitis externa. This is caused by the spread of an external canal infection to the bone and soft tissues of the skull base, predominantly caused by Pseudomonas. This is very common in immunocompromised or diabetic patients. They would usually present with severe pain, discharge, granulation tissue in the ear canal, and cranial neuropathies involving cranial nerves 7, 9, 10, and 11. This is how your malignant OE would appear. So CT scan should be done to check the extent of the involvement. And IV antibiotics with anti-Pseudomonas coverage should be started ASAP in the form of your ciprofloxacin, imipenem, ticarcillin. The comorbid problem should be managed as soon as possible, and if as much should be controlled. Surgery is not indicated. However, this has a very poor prognosis with 60% mortality, and usually this is related to the extent of the disease and the response of the patient to the therapy. For non-infectious cases, let's go to the auricular hematoma. So this is caused by blunt trauma, a shear injury at the anterior auricular skin due to contact sports or child abuse. So hematoma is an accumulation of blood between the cartilage and perichondrium, which results to the deprivation of blood supply. So there is a formation now of a fluctuant anterior ear swelling. So this picture I'm showing you is an example of an auricular hematoma. The last photo, or the third one, is a cauliflower ear, which is a complication of an auricular hematoma. So the treatment, the easiest you can do is needle aspiration, but as much as possible, you do incision and drainage, because in needle aspiration, there is a high risk of recurrence. And then after doing your IND, you should do your compressive dressing and you give antibiotics to the patient. So the complications are abscess formation and formation of cauliflower ear. How about keloid? So this is very common in the OPD. So keloid are firm, rubbery, fibrous nodules that form the ear after minor trauma. The most common is ear piercing. They are usually hard to get rid of because they have a very high recurrence rate, and usually dermatologists would require combination treatments other than surgery. So the main treatment for this is surgical removal followed by intralesional corticosteroid injection. Usually we give triamcinolone. For severe cases, radiation and laser therapy are advised. Sometimes retinoid creams and silicone gels would improve the status of your keloids. For foreign bodies in the ear, you can have animate and inanimate. Your animate are the insects, the seeds. In inanimate, commonly what you can see in your clinics or OPDs are cotton, paper, pellets, beads, and this is common in children around 2 to 4 years old. If you find an insect inside an ear canal, please do not remove with improper instrument. Try to drown the insect first with oil, and then you can remove it with proper instruments, or you can refer to an ENT. As for the seeds, please do not put water as they may grow. So adequate lighting and proper instruments are very important in removal of foreign bodies. If it is too painful, you can put topical anesthesia like your lidocaine. This is an example of a pellet stuck inside the ear of a patient. These are the photos I got from the internet. An insect, a pellet, cotton, and a seed. Here, this is an actual photo of a patient in my clinic wherein he accidentally left the cotton in his ear canal. This was removed successfully. Let me show you a video of a patient wherein I was able to remove a live cockroach inside his ear. And the other most common ear problems you would see in our clinic is the impacted cerumen. So what we do here, we can do manual extraction or ear flushing after application of ear softener. Next, the congenital problems of the ear. The most common is the preauricular sinus, wherein it appears as a small dent adjacent to the external ear, usually at the anterior margin of the ascending limb of the helix. Usually, they do not have other additional symptoms unless it becomes infected. Surgery is indicated if infection or other complications arise. Over 50% of the cases are unilateral and this is inherited. The congenital microtia or anotia. Microtia is a term used to describe a smaller and usually malformed auricle. It has 4 gradings. Grade 1 is slightly smaller than normal ear with essentially normal features. Grade 2 presents an auricle that is rudimentary and malformed but contains some recognizable components. For grade 3, this is the classic peanut ear, which is severely attenuated with a small lump of deformed tissue, often containing some cartilage. For grade 4, this is anotia. With oral atresia, this is a birth defect that is characterized by hypoplasia or aplasia of the external auditory canal. This is often associated with dysmorphic features of the auricle, middle ear, and occasionally inner ear structures. Let's go to the malignancies of the ear canal. I will be presenting only the top 3 most common malignancies we can find. This is very rare to have malignancies in the external auditory canal, but the most common is the squamous cell carcinoma, compromising around 70%. The principal risk factor is still fair skin, UV exposure with sunlight, and immunosuppression. Patients would usually present with chronic discharge, bleeding, otalgia, and hearing loss associated with or without facial palsy. The treatment still remains with surgery and radiotherapy after. Second is the basal cell carcinoma. This is very rare, occurring in 1 per million population. Usually, they are locally aggressive in nature and lack of regional lymph node metastases. Treatment is still surgical. The last one is melanoma. Melanoma is a malignancy of pigment-producing cells or the melanocytes present predominantly in the skin due to increased exposure to sun. This is a very lethal disease as it accounts for 65% of all deaths from skin cancers. 7% of the head and neck melanomas involve the ear. The treatment, still surgical. In summary, to differentiate otitis externa with otitis media, the most important is to visualize the tympanic membrane. In otitis externa, you will always have a normal tympanic membrane, whereas in otitis media, there is bulging or perforation of the eardrum. Both may present with discharges and fever. Both may present with tragus sign, or mostly on otitis media, it doesn't have. In otitis externa, the external ear canal is usually swollen as compared to your otitis media. So this ends my lecture and hope you learned something today. Thank you and God bless.